Okay. A 52-year-old woman comes to the office for a maintenance health maintenance examination. She has no serious illness. She has no serious illness, takes no medication. Menopause occurred a year ago. She does not exercise. She does not exercise. Her diet consists mainly of meat, potatoes with very few vegetables. She drinks one beer daily and 4 to 5 large cups of coffee daily. She had smoked a pack of cigarettes daily for 20 years but quit 10 years ago. She works as a mechanic. She has no family. She has no family history of cancer. Wishes to know what can we do to reduce her risk to breast cancer. The patient appears well. She is 5 feet 6 inch tall, weight 95 kg, BMI 35 kg per meter square. Vital signs are within normal limit. Physical examination shows no abnormality. Which of the following is the most likely to reduce the patient risk of breast cancer?
Ready?
Obesity can cause breast cancer.
I don't know. I just thought obesity more testosterone to estrogen and stuff like that.
Okay.
I don't.
Yes, that was the sign. I remember that picture. Okay, ready.
Ready.
There was a picture in the world like obesity.
Um, Exercising and reducing caloric intake is the most likely to reduce this patient risk of breast cancer. Breast cancer is the most common non-dermatologic malignancy in women and commonly present with breast mass, skin or nipple retraction, axillary lymphadenopathy. However, it may also be asymptomatic and diagnosed on scanning mammography. Risk factors for breast cancer development include family history, premenopausal breast cancer, BRCA mutation, early menarche, late menopause, nulliparity. There are also several modified risk factors, including obesity, exogenous estrogen administration, alcohol and tobacco use, a lack of physical activity. Postmenopausal obesity specifically is associated with increased morbidity and mortality related to breast cancer. Treatment for breast cancer depends on its stage at diagnosis. In patients with early stage disease, treatment consists of surgical removal of the tumor and axillary lymph nodes, along with adjuvant systemic hormonal therapy, biologic therapy, or chemo, with which depends on estrogen, progesterone, and HER2 positivity of the cancer. Patients with advanced breast cancer are typically treated with lifelong palliative systemic therapy only. Alcohol cessation may decrease this patient risk. Oh, yeah, may decrease this patient risk for. Well, she's not really drinking that much. Raloxifene therapy is an estrogen modulator that's most commonly used in treatment of osteoporosis, as well as in the prevention of postmenopausal breast cancer in patients at increased risk for its development. While effective in decreasing breast cancer risk, is associated with increased risk of thromboembolism, as this patient is at average risk for breast cancer with no history of previous premalignant lesion. Exercise and weight loss will be more appropriate. Okay.
Okay. A state-supported academic health and insurance system is contracted across a large set of Western United States to cover the aspects of the care for patients of all age and income level, including the Medicaid and the Medicare population. The system's goal is to provide the highest quality of care in the most efficient manner to all patients equally and to support productivity of the population in that state. The organization already has many skilled providers within very within every specialty, but they also wish to prioritize key areas to proactive improvement. Which of the following strategies is most likely to be effective in achieving this goal? Are you there?
Yeah, say ready. I couldn't hear you.
Okay.
Ready?
I don't know what is the answer. Okay, let's see.
Oh, can you hear me?
Sorry.
Can you hear me?
Yes, I can hear you.
Okay, okay. Because I was saying ready and you didn't. You were saying I was like maybe she cannot hear me. Okay, it's increased
I haven't
relative.
heard you. That's why.
Okay. Increased relative investment in primary care services. Quality improvement is a framework that seeks to systematically improve and standardize the performance of a healthcare system. This vignette describes an intervention aimed at improving population health. Primary care has been shown to improve population health and decrease health disparities. The vast majority of medical care is delivered through primary care. As well as primary care commonly uses primary prevention strategies. Primary prevention strategies aim to prevent the effects of disease before the disease occurs, like diet, exercise, to prevent obesity and diabetes. Primary prevention strategies are effective across diverse populations and are therefore an efficient means of increasing productivity by preventing disease occur across a population. Don't know what that means. Okay, it's not B, C, D.
Is that primary care what like that means like you go to doctor and it covers your insurance. This is the primary care.
I,
You
I don't know.
like you give an example regarding your family. Then I will understand. You got my point because I am not accustomed with the US medical system. You got my
I
point,
don't,
what I'm trying to say.
I don't
Like,
know what they mean by primary care. I think they mean family medicine doctor.
okay.
I
And
think
if
that's
you
what it.
need specialized, like, suppose you need a surgery, like,
Mhm.
uh, uh, suppose you have, suppose you, I'm not saying, suppose you have gallbladder stone, then what will happen?
Usually depends on your type of insurance. Some insurance you have to go to your family medicine doctor, and then he is the one that's going to refer you to a surgeon. He's going to tell you, okay, we work with this surgeon, so you have to go to him. Now it
You can't choose anybody.
depends on your insurance. If you have an insurance, they have some insurance that are limited, and you have to go first to family medicine, and family medicine sends you to surgery. Then they have other insurance where you can pick whatever surgeon you want. Then they have other insurance that if you pick whatever surgeon you want, you have to pay something. The insurance pay half and you pay half.
Oh,
So it depends on your insurance. Yeah, the type of
and
insurance.
this insurance now how it depends what like Insurance depends on what? Your job status, your social status. What does
No,
the
and the one you can afford. So the job can give you insurance, or you can just buy your own insurance, or if you're I think the old people have the government give them insurance. I think it's the Medicare,
yes,
and then
it is after 55, isn't it?
yeah, I think 55 or 65, I'm not sure.
Okay.
And then you have disabled people also have Medicaid. So depends on the one you can afford. Some people don't, they just buy it. I don't know where they buy it, but yeah, they buy it.
But it is
And
very costly, isn't it?
yeah,
Uh,
it's very
uh,
costly.
like I
Hmm.
am talking about laparoscopic cholecystectomy. It is very costly. I think so.
Yeah, it's very costly. So it's better when you have an insurance, and good insurance. Because some insurances will
And
say, oh,
if somebody has like acute problem, then if your insurance does not cover, but you have acute problem like acute appendicitis, you need emergency surgery, then
and you don't have insurance, you
yes,
can go, they will do it, but then you have to pay.
okay, I have to pay. Like I have to pay till my death, isn't it?
Yeah,
Okay.
yeah, yeah, basically. But I don't think they can refuse you. Mostly if it's acute, they you go to the emergency. They
But if it is not emergency, they will not gonna accept. You need the
probably not.
insurance.
Probably not. Yeah.
Okay. Okay, got it.
Okay. Eliminate prior authorization requirements and expand drug formularies to include more prescription options. Establish a mobile clinic to bring specialty service directly to underserved areas, and expand telemedicine service will improve the health of certain subpopulations only. Expanding drug formulas and eliminating prior authorization requirements will affect only patients requiring specialized medications. Establishing a mobile clinic and expanding teleservices will increase health outcome for rural populations or subpopulations without easy transportation, not the entire population. Expand insurance access for specialty, advanced imaging, and surgeries may increase health in a subpopulation with suboptimal insurance. However, it will not improve population health for the entire population. Additionally, specialty services provide tertiary prevention, which is defined by preventing complication of existing disease rather than primary prevention. Primary prevention applies to more of the population than tertiary prevention, and tertiary prevention only applies to subpopulation that already have the disease. Okay.
Okay. A 6-year-old girl is brought to the office by her mother for a well child examination. The mother is concerned about the mother is concerned about nighttime the mother is concerned about nighttime bedwetting, reporting that although the patient has been toilet trained for the past 2 years during the daytime, she has never had dry night. She has never had a dry night. The patient has three siblings. The patient has three siblings who the mother states were all dry through the night, and by the age 5 years the patient is otherwise healthy and vaccinations are up to date. Vital signs are within normal limit. Physical examination shows no abnormality. Fasting finger stick glucose is 82 milligram per deciliter. In analysis within normal range, which of the following is the next step in the management?
Hmm. I think there's no pressing. Ready?
Yes.
With reassurance, neuresis is in approximately 15% of children and is defined as episodes of urine incontinence in children 5 years and older. Neurosis is divided into monosymptomatic and non-monosymptomatic types. Monosymptomatic neurosis refers to nighttime bedwetting in children with no other lower urinary tract symptoms or history of bladder dysfunction can be further classified as primary or secondary. Primary monosymptomatic enuresis refer to enuresis in children who have never been previously continent at night. While secondary monosymptomatic enuresis refers to enuresis that develops after a prior of at least 6 months of nighttime continence. Nocturnal enuresis occurs as a result of combination of factors, including maturation delay, genetic factors, disturbed sleep, and the closure of activity. Evaluation of patients with nocturnal enuresis should include a thorough medical history and physical exam, as well as urinalysis with the goal of determining whether the patient has an underlying pathologic condition for the that causing the bedwetting. Each story should focus on presence of any lower urinary tract symptom, frequency and trend of bedwetting episodes, stooling history. Social history urinalysis is done to screen for diabetic ketoacidosis, diabetes insipidus, or UTI. In almost all cases, monosymptomatic nocturnal enuresis resolves spontaneously. For patients and parents who view enuresis as a problem interfering with social life and wish to seek treatment, there are several options available. Primary management for enuresis involves treatment of existing conditions, patient and parent education, motivational therapy, and reassurance. If the patient is still having bedwetting episode after 3 to 6 months of initial therapy, desmopressin therapy or enuresis allowance may be continued. It is not desmopressin therapy is secondary treatment option to enuresis is only recommended in patients who have no improvement in symptoms after 3 to 6 months of primary management. This patient does not meet the criteria yet. Fluid restriction after 2 p.m. is incorrect. Limiting fluid intake in the evenings after 5 p.m. can be considered as part of initial management, but it should be done carefully as with the corresponding increase in fluid intake in the morning hours. Yeah. Restricting fluid at 2 p.m. would likely lead to inadequate fluid intake. Um, yeah, I think that was it.
So, aneurysms can come
Mm-hmm.
like after aneurysms can come after the patient learn about dryness at night. Okay, it is normal. Just reassure. Okay.
Mm-hmm.
A 44-year-old man comes to the office because of 5 year history of a lump on his upper back. 4 months ago, the lump became tender for a week when he had been exercising at the gym more often. But the tenderness resolved spontaneously. He says the lump has not changed in size and he has not noticed any skin changes. The patient is worried that the lump could be cancerous. He has no history of serious illness, takes no medication. He is 183 centimeter, weight 82 kg, BMI 24 kg per meter square. Vital signs are within normal limits. Physical examination shows 4 centimeter non-tender, moderately firm, mobile mass between the right scapula and the spine. No other masses are palpated. Ultrasonography of the lump shows a well-defined mass with a homogeneous ecotexture. Which of the following is the most appropriate next step in the management? Mobile masterpiece. Mobile.
Ready?
Is it lipoma?
I think so.
Okay.
For its continued observation, lipomas represent benign tumors of mature adipocytes. Lipomas can develop at any age, and there is limited knowledge regarding the pathogenesis of the benign tumors. Clinically, lipomas present as solitary, painless, soft, mobile, subcutaneous tumor which range from a few centimeters to 10 centimeters diameter. Pathologic examination of lipoma shows mature adipocytes with small, uniform, eccentric nuclei. In cases of asymptomatic lipoma, clinical monitoring is appropriate. If patients seek definitive management secondary to symptoms or appearance, lipomas may be excised, though they are generally considered benign and harmless. They are a rare chance of transforming into malignant neoplasm like liposarcoma. Seasonal biopsy is used to diagnose cutaneous neoplasms, including melanoma. Seasonal biopsy allows for removal of an entire suspicious lesion and permit histologic diagnosis, while excisional biopsy may be used for suspicious masses. The clinical exam and ultrasound findings in this case are consistent with lipoma. Fine needle biopsy may be used to diagnose subcutaneous tumor, including breast masses and thyroid nodules. Fine needle biopsy are often completed with ultrasound guidance to identify the region of interest, aspirate the tissue, and subsequently complete histologic exam. While fine needle biopsy may be used for the diagnosis of subcutaneous nodules and tumors, it is not recommended for benign lipoma. Okay, next.
A previously healthy 19-year-old man comes to the physician because of 1 week history of sore throat, difficulty swallowing, and fever. Difficulty swallowing and fever. He has muffled voice. His temperature is 103 Fahrenheit. Which of the following would warrant the need for surgical intervention? So, muffled for surgical intervention.
Ready?
What does he have? Epiglottitis.
I do not know for this diagnosis.
Okay, let's see.
Lateral deviation of the uvula. This patient
Sorry.
likely has peritonsillar abscess. Peritonsillar abscess is localized accumulation of pus between the palatine tonsil and the pharyngeal muscles. It is potentially life-threatening condition because of the risk of for local swelling and compression of the airway. It is most commonly in adolescents, particularly those with recent history of prior tonsillitis or pharyngitis. While the infection is often polymicrobial, gram-positive organisms such as strep and staph patients may predominate. Patients such as this one present with fever, sore throat, trismus, localized swelling and fluctuance of align the tonsils, lateral deviation of the uvula, and may show signs of airway compromise, such as muffled voice and drooling. Diagnosis is clinical but may be supported by radiographs. Treatment involves surgical intervention such as needle aspiration or incision and drainage of the peritonsillar space, and antibiotic therapy to provide broad coverage of likely pathogen. It is not, see, let us see. A petechiae over the soft palate and pharyngeal exudates what is it? Can all be present with bacterial or viral meningitis. While present in this patient, they do not indicate the presence of, of a peritonsillar abscess or other structural compressive lesion that would require surgical intervention. Peritonsillar abscess um, is indicated by the presence of muffled voice, trismus, pharyngeal asymmetry, and uvular deviation. Tenderness of the trachea can be a symptom of tracheitis. Patients with tracheitis can present with stridor. Stridor refers to a high-pitched sound secondary to turbulent flow from an underlying upper airway obstruction, often as a result of inflammation. It's not a symptom of pharyngitis or peritonsillar abscess, and it's not a condition that can easily be treated by surgical intervention. Rather, attention should be paid to airway management, including the potential need for intubation and mechanical ventilation, and treatment of common pathogens by giving antibiotics. Next.
So in here, catch is muffled voice, fever, difficulty swallowing, muffled voice, and
Um,
there is lateral deviation of the uvula.
yeah.
There is another thing like Ludwig's angina. That was the surgical emergency. Then how we can differentiate? But
I thought, okay.
Ludwig's angina has like after dental extraction, and there
Mm-hmm.
is like emphysematous bulla like lesion around the shoulder, as far I remember. Okay,
I thought Ludwig's angina was the one under the tongue.
and under the tongue,
Yeah. Wasn't it that one? No. Am I
maybe.
wrong? Mm, Ludwig. Yeah, it's the one that's mandibular. Oh, mandibular molar dental. Yeah, the under the tongue one.
And it is also surgical emergency,
Mm-hmm. Mm-hmm.
like this kind of peritonsillar abscess. Okay.
Mm-hmm.
A 37-year-old man comes to the physician because of 6 week history of epigastric pain. The pain is most severe 1 hour after. The pain is most severe 1 hour after eating and is relieved by over the counter antacids. He has no fever, nausea, and weight loss. He has hypertension treated with hydrochlorothiazide. He does not smoke, drinks 1 glass of wine with dinner daily. Pulse is 76 per minute, blood pressure 136 by 80. There is mild epigastric tenderness without rebound and guarding. The stool is brown. Test for occult blood is negative. Hemoglobin is 13.8. Liver function has no abnormality. Which of the following is the most appropriate next step in the diagnosis? Epigastric pain. One of liver. Okay, okay. Ready?
Mm-hmm.
What is your diagnosis?
Don't have a diagnosis in this one. Okay. It's H. pylori. Serum H. pylori antibody assay. Peptic ulcer disease describes the presence of ulcers in the stomach and the duodenum, which classically presents with worsening abdominal pain related to consumption, gastric, or lack of consumption, duodenal. Yeah. This patient has chronic history of epigastric abdominal pain after eating that is relieved by antacids. Okay. Making peptic ulcer disease likely. Gastric ulcers can be caused by prolonged or excess use of NSAIDs, which leads to reduction of prostaglandin secretion and decreased protection of the gastric mucosa. However, the most common cause of peptic ulcer disease is infection with Bacterium H. pylori, which accounts for nearly all duodenal ulcers. Thus, serologic testing for H. pylori with antibody assay should be done. Radiation therapy uses a triple or quadruple combined therapy for H. pylori can eliminate the bacterium and permit healing of the peptic ulcer, generally with few complications if managed promptly. It's not esophageal pH monitoring is a test used in the diagnosis of GERD when clinical findings of esophagogastroduodenoscopy are not adequate to confirm a diagnosis. GERD presents with chest discomfort, often in association with consumption of a large meal or trigger food such as we know the foods. It's often worse with supine positioning. This patient's symptoms arise 1 hour after consumption, and he has more epigastric rather than chest discomfort, making peptic ulcer the blah, blah, blah. And it's not, I want to read the other two, I guess. Abdominal ultrasound is the first line diagnostic exam for evaluation of potential cholelithiasis cholecystitis. Cholelithiasis can present with postprandial epigastric or right upper abdominal pain. Acute cholecystitis occurs secondary to obstruction of the cystic duct from gallstone, which results in subsequent inflammation of the gallbladder wall with fever, right upper quadrant pain, tenderness to palpation, often in a patient with history of gallstones. This patient has no history of blah 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 and blah blah blah. Abdominal CT is clinically useful in diagnosis of peptic ulcer disease, of complicated peptic ulcer disease. If left untreated, peptic ulcer disease can be complicated by fibers, stricture, hemorrhage, or perforation. Perforation commonly presents with peritonitis, fever. X-ray and abdominal can be identified air in such a circumstance. Okay, next.
Okay. BH. Okay. I thought it's GRD. Okay. A previously healthy 47-year-old woman comes to the office 4-week history of palpitation and feeling hot, sweaty, and anxious. During the past 2 months, she has had 3.2 kg weight loss despite a normal appetite. She has not had chest pain, shortness of breath, lightheadedness, dizziness, nausea. Her last menstrual period was 3 weeks ago. Mens previously occurred at regular 30 days intervals, but she notes that during the past year she might have missed the periods. She does not smoke cigarettes. She drinks 1 glass of wine monthly. She is 5 feet 5 inch. Weight is 61. BMI is 23. Pulse is under 12 per minute and regular. Respiration are 16 per minute. Blood pressure 138 by 88. Examination shows no other abnormality. Her serum TSH hormone is zero point 0.1. Results of additional lab studies are pending. Which of the following is the most appropriate next step in the management?
Ready?
Wait 1 second. Okay.
So it's thyroid ultrasound. Damn it. This patient is presenting with signs and symptoms of hyperthyroidism. We know that. The patient was found to have low TSH, indicating that the cause of her hyperthyroidism is likely primary type, like Graves' hyperfunctioning thyroid nodule. On physical exam, the patient shows no signs or symptoms of a discrete thyroid mass. All patients with signs and symptoms of hyperthyroidism as well as low TSH concentration should undergo thyroid ultrasound along with testing for thyroid stimulating antibodies. Ultrasound guided fine needle aspiration biopsy can be performed at the same time, which is recommended for patients with risk factors for malignancy or for nodules with the concerning ultrasound features. Subsequent workup and management is dependent on the results of the TSH concentration, measurement, antibody detection, iodine uptake testing, characteristics of the nodule shown on ultrasound biopsy result. Of this option, ultrasound is the best next step. Admission to the hospital is not necessary currently. Patient does not display any unstable vital signs, really, or features within her history for examination that mandate hospitalization. Outpatient testing for hyperthyroidism can be performed for this patient given her stability. Should she develop signs of severe hyperthyroidism or thyroid storm, inpatient management will be warranted at that time. Mm, okay.
Okay. Is there any flow chart like what to do first thyroid ultrasound, then what will do next?
I feel like there is, but
Sorry,
there should be hyperthyroidism. Mm,
how is your brother?
he's
I was
okay.
thinking all that.
I haven't spoken to him today. They have 1 week to, so he has to remove
Like
everything.
Trump told the US government they will take 2 weeks time, then they will gonna attack. Uh,
Oh,
Actually, in
really?
this, yes, in this 2 week, they actually preparing for the war. They
Wait,
are,
when did he say that?
sorry,
When did Trump say that? Like today? Like,
N- it is in that you have Truth Social. In their Truth Social is the Trump's own social media where he actually posts. You can read from there. You have I don't know you follow the news or not. Most of the news they Trump did not post on the X. He actually post on the Truth Social. So I
mm,
have an account, so I can see from the
so he said that in 2 weeks they're gonna
they
attack.
in these 2 weeks they will gonna wait and they will try to communicate with the Iran, and then they will decide they will do the war or not.
Oh my God.
And they are preparing like the news, like according to the news they are actually accumulating the US force towards the Iranian uh, what can I say, Iranian sea.
Mm-hmm.
And another thing I know, like actually Israel is escalating to got into they actually call the US to get into this war because they cannot alone cannot fight with this war because they haven't enough resources to fight against the Iran. That is the truth. And
Yeah, that's
they are actually escalating. Iran said the clear words that we are talking with US. Why you are bombing on us as we are trying to communicate with the US?
mm-hmm.
They actually throw bomb when they are talking with the US. Iran actually do not want this war because war is bad for everyone. They actually know, and Iran since last 10-15 years Iran is like isolated from the whole Middle East
Yeah.
because the US government has sanctioned plenty of obligations that they do not uh, uh, get into business with other countries, so that's why they are isolated.
Oh
and
my.
and the bad thing, they are actually escalating on the Israelis escalating, and on the other hand, the Russia China, along with the North Korea, who is the very crazy Kim Jong Un, the
Mhm.
person whom Trump actually met in his country. He's a very what can I say? He's a very madman. So
Yeah.
they are with Iran. So if the war starts, then very bad thing will happen.
I of course it's a war. Oh
Because
my god.
because and the most bad part what is they are waiting for I have told you yesterday the B2 bomber which is an which can destroy the underground atomic energy source destroy
Mm-hmm.
if Iran is suppose Iran is made atomic bomb and you are bombing on that atomic bomb, then what will happen?
Mm-hmm.
The whole world will suffer. It
Yeah.
is not the only Iran's thing, it is whole world's thing.
Yeah. That is
And
true.
that if it happens, then whole world will suffer. That's why everyone is telling that not to involve in this war. They are actually stopping US government. But I don't know US government has something behind them. They are actually pushing, throwing them into the war.
Oh Jesus.
If it happens, like a very bad thing will happen for the
Of
whole world,
course.
not for Iran, not for anybody.
Yeah.
Because if atomic energy will burst, then you know what will happen. You know what happened in the Hiroshima and the Nagasaki.
But it like if it explodes there, it doesn't get
If
all the way.
if it explodes,
Mm-hmm.
it because it is a full uh, a uranium production area like and it they actually doing it for like making what can I say electricity and other things. If this uranium comes along with the blast, then
Mm-hmm.
a very bigger area will explode and the explosion will spread can spread any country.
Oh my god.
Yes, that's the most sad part. You can't you can't stop that. You can't stop that.
You
In the
think it
you
can explode
sorry
there and you think it can explode there and get to the US? Like the explosion can get,
it
or you mean
it
the
can come,
smoke?
it can come,
Smoke,
smoke can come,
the smoke.
smoke can come because like atomic bombing is very bad. It has the capacity to spread in the air and can spread in
Mm-hmm.
anywhere.
Mm-hmm.
And from Middle East to US, not so far.
It's not so far. Oh my goodness. Oh,
Everybody wants the peace, but I don't know if I think that if Netanyahu is if anybody stops the Netanyahu, then everything will stop.
Jesus. Oh,
Okay, let's study.
yes,
And I think that the US people choose again the wrong person.
definitely.
He
Yeah,
he comes with so much uh, what can I say? He comes with so much hope of the people, but
they hardly even
he's
work.
putting for his fame, for his name, he's
Mm-hmm.
putting US into a death threat actually. Okay,
This one. Next.
okay. That's why I'm thinking about like what has happened because like if your brother goes, that means the whole thing is like they are preparing for the whole war, isn't it? Like,
Yeah, yeah, because I was like, it doesn't make sense. Why do you guys need to go if there is no work?
yes,
Why there is this? It doesn't
and
make sense.
and if it starts, like if it starts, It may extend like the like very long time if it starts. It
Yeah,
will
because
not go, it will not gonna stop in a day.
they told him he's gonna be there until next year, like February of next year.
Oh,
So it's not
so
like he's
think
doing it.
they what they are planning. That is
Yeah,
the most sad.
yeah.
Okay,
Okay.
we should not think about that.
Yeah.
But the like economy like problem is for everybody. Like if
Yes.
suppose think about like if US economy is false, every person of the US will suffer.
Yep. That's true.
Okay. A 25-year-old woman comes to the office because of 6 months history of difficulty sleeping, feeling worried, and aging most days. She has been a patient for the past 10 years. She has no history of serious illness. He, her only medications is oral contraceptives. She works as an emergency she works as an emergency room technician, but is applying to nursing school next year. Vital signs are within normal limits. Physical examination shows no abnormalities. On mental status examination, she has anxious mood and jittery effect. Which of the following is the most appropriate next step in the management?
Hmm. What does she even have? 6 months. Oh,
6 months.
like God,
Sorry.
like generalized anxiety. I don't know. I don't know. Do we give them benzos? That makes sense. Ready?
Yes.
Okay. So we do office-based counseling. The diagnosis of GARDIA requires the presence of excessive worry about numerous aspects of daily life occurring one more days than not for 6 months with consequent inability to control symptoms of anxiety in the presence of at least three other symptoms like including irritability, muscle tension, sleep problems, poor concentration, fatigue, restlessness. GAD may be associated with sympathetic hyperactivity, such as sweaty palms and panic attacks. The treatment depends on symptom severity. For mild GAD, that does not affect daily function as seen in this patient, who still functions as an emergency room technician. Office based counseling is appropriate initial step. This patient anxiety should be monitored over the next few months. If office-based counseling is ineffective, or if this patient presents with more severe dysfunction, SSRIs and cognitive behavioral therapy should be started. Prazolam benzo medication can be used in refractory anxiety disorders in patients without substance use history. Benzos do not play a role in initial treatment of GAD as seen in this patient. Benzos are commonly used to manage anxiety as a transient side effect of SSRI. As well, the patient's GAD is mild, so efficient office base should be enough before medications. Okay, next.
Okay. A 14-year-old boy is brought to the physician because his parents are concerned that he is shorter than his classmates. He is at 10 percentile for height, 25 percentile for weight. Both parents are at the 75 percentile for height. His diet consists of cereal, milk, bread, and fried food. The patient's temperature is 37 degrees Celsius, pulse 75 per minute, respiration 12 per minute, blood pressure is 110 by 65. Examination shows sparse facial hair, sparse straight, slightly pigmented hair, and the base of a slightly enlarged penis. The skin is warm and moist. The testes are approximately 3 centimeters long and are descended into the scrotum bilaterally. Testes 2 centimeters, 3 centimeters. X-ray show bone age is 12 plus minus 4 months. Which of the following is the most appropriate?
Ready?
Yes.
So it's constitutional growth delay. This patient most likely diagnosis is constitutional growth delay, which is a normal variant of growth. Short stature has a variety of causes, such as constitutional growth delay, familial or hereditary short stature, chronic steroid use, endocrine abnormalities like hypothyroidism, adrenal insufficiency, cardiopulmonary disease, and genetic disorders like Turner and Down. Familial short status and constitutional growth delay are the most common causes of short status. Constitutional growth delay is independent of parental stature, has a consistently decreased growth velocity, and a born age younger than chronological age. Patients with constitutional growth delay may experience a delay onset of puberty. These patients typically reach a normal adult height with more rapid increases in high gain velocity as they progress to puberty. Familiar stature short delay. Familiar stature short stature typically presents in young patients whose parents are both short, with a normal growth velocity and bone age consistent with chronological age. Okay. These patients will remain short into adulthood. Non-nutritional deficiency typically results in abnormally low weight, along with signs of malnutrition such as dry skin, hair loss. The patient has normal weight. What is the weight? Don't say. Yeah, okay. And lacks physical of malnutrition. Normal development associated with bone age that's consistent with chronological age, which is not seen in this patient. Additionally, he has several standard deviation below the expected height for his height.
Okay. Let's jump into studies.
Yes.
Okay. A 70 a 70-year-old man comes to the physician because of 1 week history of progressive shortness of breath and swelling of his legs. Progressive shortness of breath and swelling of his legs. The shortness of breath now occurs after he walks for only a few minutes and limits his ability to climb stairs. He uses two pillows to sleep comfortably. During the past week, he has had 4.5 kg weight gain despite a normal appetite. Despite a normal appetite, he has 10-year history of metabolic syndrome and a 6-year history of chronic obstructive pulmonary disease. 7 years ago, he sustained myocardial infarction and subsequently underwent uncomplicated coronary artery bypass graft of 4 arteries. His medication are furosemide, clopidogrel, metoprolol, lisinopril, aspirin. 3 days ago, he doubled his doses of furosemide without the physician's knowledge. On querying, he says he has not had increased urine output. He has smoked a pack of cigarettes for 50 years. His pulse is 110, respiration 22, blood pressure 160 by 95. Pulse oximeter on room air shows oxygen saturation 86%. Examination shows jugular venous distension. Crackles are heard halfway Both lungs histories are no murmurs are heard. There is 3 plus pitting edema of the lower extremity. Which of the following is the most likely cause of these patient symptoms?
What is metabolic syndrome?
Metabolic syndrome uh, comes with diabetes.
Diabetes?
Yes. Mm,
Mm,
like early onset diabetes, this kind of feature, I think so.
between that and ischemic cardiomyopathy, metabolic syndrome. Ischemic cardiomyopathy, he will have
S3 is
chest.
present, heart presence of features of
Yeah,
heart failure, and JVT is distant. Everything goes with the heart.
yeah. But ischemic cardiomyopathy, shouldn't he have chest pain? No, maybe not. Okay, maybe not.
Even if
Ready?
he increase the dose of the furosemide,
Mm-hmm.
nothing actually improves. So
Mm-hmm.
his heart is not working well,
Okay.
probably.
Ready?
Okay, let's go.
Yeah, you're right. It's ischemic cardiomyopathy. This patient with dyspnea and exertion, autopnea, peripheral edema, presentation with ischemic cardiomyopathy, a kind of CHF, congestive heart failure. Physical exam classically shows peripheral edema, JVD, bibacil rails, and S3 or S4 sound. If taken, checks X-ray will likely show pulmonary edema and cardiomegaly. And lab study will show increased BNP concentration. Echo is the gold standard for diagnosis of CHF and may show either reduced ejection fraction. In the case of systolic heart failure, a preserved ejection fraction in diastolic. There are numerous causes of heart failure, including ischemic heart disease, hypertension, valvulopathy, pulmonary disease, infection, arrhythmia, congenital causes. Treatment of CHS involves management of underlying cause and associated condition, as well as appropriate treatment, pharmacotherapy to improve symptoms, preserve myocardial function, and reduce mortality. Initial recommended therapy generally includes combination of 5 classes of medication, beta blockers,
RAS,
renin
RAS
angiotensin,
inhibitor, yes.
RAS inhibitor, diuretic, and mineralocorticoid antagonist, and SGLT inhibitor. Treatment decisions are often nuanceable depending on the severity, whatever. It is not the metabolic. Wait, never mind. I'm going to the other question. Metabolic syndrome. Okay, it's not. I cannot read that one. I'm going into the other question. Next.
Okay, next. Okay, question 2 by 2. The patient is admitted to the hospital. Echocardiography show left ventricular ejection fraction 20% global. Hypokinesis, no evidence of MI. In condition, sorry, in addition to continued furosemide, which of the following is the pharmacotherapy is most appropriate pharmacotherapy? Uh, he's getting is in door. Okay. Okay.
One moment.
Yes.
Restaurant antagonist.
I got too much adrenaline after reading those type of news.
Oh my lord. Okay.
There is a problem in my brain.
Oh my goodness. Okay, ready. It is aldosterone antagonist. This patient with dyspnea on
I
exertion.
got rejected from the Air Force because of my height and
Oh,
weight.
oh
I
really? You wanted
yes,
to join?
I passed the exam, but there is a requirement of height and weight. So
Mm-hmm.
I failed in both categories. So I cannot
Oh,
get
no.
into next.
Oh, but you wanted to join. That's nice. I didn't know. You wanted, oh. Hmm. Okay, we already read all of this.
Okay, I think that
Yeah.
it is. We know that this answer
But why is not angiotensin 2 receptor
because
blocked?
he is on. Yes, he is on angiotensin. He is on AC inhibitor. He is on lisinopril. He
Wait,
is
let me.
already getting the lisinopril.
Oh, okay. Sorry. Yep, did not see that one.
Okay.
Okay. Wait, let me read this one. I
Yes.
didn't.
Okay.
Metabolic syndrome is characterized by constellation in insulin resistance, hypertension, high cholesterol, dominant obesity. Patients with metabolic syndrome are increased risk of developing heart disease, but metabolic syndrome will not cause this patient presentation. Okay, got it. Next.
Which of the following is the most likely causal organism? A 72-year-old man comes to the physician. A 72-year-old man comes to the physician because of 2 day history of moderate back pain, fever, chills, nausea during this time. He has also had burning sensation with he has also had burning sensation with urination and urinary urgency. He has 3 year history of BPH. He has 3 year history of BPH characterized by incomplete voiding and intermittent urges to void during the night. Intermittent urges to void during the night. His medication are tamsulosin and aspirin. He appears ill. Temperature is 102. Uh, Percussion of the back elicits moderate discomfort. Abdominal examination shows diffuse tenderness to palpation, but no rebound or guarding. Urine, dipstick testing, 2 plus blood, positive nitrate, positive leukocytosis. Which of the following is the most likely causal organism?
Ready?
Yes.
Okay, so it's E. coli. Pyelonephritis occurs because of retrograde spread of lower urinary tract infection. Urinary tract infection (UTIs) are most common in women due to shorter urethra, whatever. For bacteria and in patients with diabetes, for bacterial growth, and in patients with diabetes due to presence of glycosuria. Men with BPH and urinary outflow obstruction create increased risk for development of UTI. Upper urinary tract infections such as pyelonephritis more commonly presents with systemic symptoms such as rigors, nausea, vomiting, myalgia, arthralgia, fatigue, high fevers, tachycardia, leukocytosis, flank pain, CVA tenderness, and such as this patient with discomfort or percussion of the back. Analysis in pyelonephritis often show greater than 10 leukocytes per height. Yeah. It may show white blood cell counts. Bacteria are generally seen on microscopy with gram-negative ROF, especially E. coli being the most common pathogen. E. coli produces nitrites detectable on urinalysis. Pyelonephritis is treated with broad-spectrum antibiotics. It's not Klebsiella pneumonia, encapsulating gram-negative bacterium that can present with lobar pneumonia, especially in patients with diabetes or alcohol use disorder. Can also cause nosocomial UTI. Um, Okay. However, E. coli is the most common cause of UTI infections that are community acquired. Okay.
Next. A 10-year-old boy is brought to the office for a well child examination. He and her, he and his family is immigrated from Bolivia to from Bolivia to USA 7 years ago. He has no history of serious illness, received no medication, immunization are up to date. He lives in a house with a built 1965. Development is appropriate for age. He is at 64 percentile high, 96 percentile for weight, greater 95 percentile for BMI. Examination no other. Which of the following is the most appropriate screening at this time?
Oh, always forgot the date for the lead. It's 1960, 1985.
Why we need to do the lead?
Why was
Because
the house built? What was the date for the there was a
1960, maybe before 1950 or 65, it can happen.
65.
But I am not thinking on that.
You don't thinking on that. You're thinking more of glucose.
No, no, not glucose. No symptoms of glucose.
Okay, you're thinking more of
He is at 95% high, 96,
to
96 percentile weight. Weight is higher. Um,
mean
is it
that
PPD skin test like TB
I'm
should be
thinking
excluded?
I'm thinking
Immigration, sorry,
of Bolivia. Yeah, because he comes from Bolivia, but mm,
like every person who came from other country to US, they have to be vaccinated, isn't it?
mm,
BCG
I don't know.
vaccination.
I don't think I don't think so. Well, it says immunization are up to date though.
I think that like we think we need to think about the BMI.
The glucose, yeah, because it says immunization are up to date. Never mind.
Yes.
Okay, let's see. Yeah, it's glucose. Measurement of glucose. In pediatric patients, being overweight is defined as BMI above at or above 85 percentile and below 95 percentile for age and sex. While obesity is defined as BMI or at above 95 percentile. This patient consumes a balanced diet, but one that most likely contains excessive total calories. More common patients of common causes of childhood obesity include consuming a diet rich in unhealthy calorie rich foods and a lack of sufficient exercise. Children from socioeconomically disadvantaged communities may face significant difficulties in obtaining healthy food and sufficient opportunity to exercise. Children with obesity are more likely to develop comorbidities such as hypertension and diabetes. As a result, this patient should be screened for these disorders. For this patient, measurement of fasting glucose concentration is the yeah. Measurement of blood lead concentration is not appropriate for this patient. Lead inhibits the enzyme peroxylatase and ALA dehydratase, resulting in decreased heme synthesis, increased ALA, alpha ALA, whatever, urinary procoporin, and erythrocyte photoporphyrin. Clinical manifestation of lead poisoning include encephalopathy, cognitive dysfunction, peripheral neuropathy, hearing loss, renal dysfunction, interstitial nephritis, vomiting, abdominal pain, constipation, and anemia, which are not present in this patient. Okay, if there is no signs, you don't measure it. PPD skin test, tuberculosis used to test for exposure to TB. TB can manifest variety of ways and can mimic interstitial disease implementation and on imaging. History of TB is a risk factor for developing interstitial lung disease. And the patient should be evaluated for any history of exposure. However, this patient has no signs of symptoms of pulmonary issues at this time. TB test may be indicated, but it's not more important than screening for diabetes. Okay.
Okay. A 9-month-old girl is brought to the physician for a child. Well, child examination. Developmental milestones are appropriate for age. She is at 50 percentile for length, 60 percentile for length, 60 percentile for weight. Her temperature is 37 degrees Celsius. Pulse is 137 per minute. Respiration 32 per minute. Blood pressure 86 by 42. Examination shows no abnormalities other than mild. Examination shows no abnormality other than mild congenital pallor. Hematocrit is 29%, MCB 65. Which of the following would be helpful to ask the patient's parents to determine the cause of the child's anemia?
Ready?
Okay.
So it's what does she eat? Neonates, and infants fed with only whole cow milk are at risk for developing iron deficiency and anemia. Both breast milk and cow milk contain low iron. The iron in breast milk has a high bioavailability, while cow milk proteins impair iron absorption in human infants. In addition to poor absorption, cow milk is associated with increase occult enteric bleeding that contributes to iron loss during infancy. Most infants if eventually tolerate cow milk later in life. Iron deficiency anemia early in life can lead to significant neurocognitive and psychomotor impairment that persists even after treatment. Has she passed any blood in the urine is not the most helpful question to ask. Hematuria um, can have any many causes. In the pediatric population, some example is blah, blah, blah. Given this patient has no recent history of illness, blah, blah, blah. Okay, that doesn't make sense. Next.
If somebody, if any baby eats formula feed,
Mm-hmm.
then this iron deficiency anemia can happen.
I don't think so because formula fed usually they have iron. They put a lot of things inside vitamins.
Okay.
Okay.
A 4-year-old boy is brought to the office. A 4-year-old boy is brought to the office because of one day history of moderate left hip pain. Walks with a limp. 10 days ago, she had a mild cough, runny nose, resolved spontaneously. He has not sustained any trauma. He has not sustained any trauma. He has no other history of serious illness, received no medications. He appears well. Vital signs are within normal limits. The left on examination, the left hip is normal position. Palpation of the left hip. Palpation of the left hip produces no tenderness. Active and passive range of movement is limited by pain. Examination of all other joints shows no abnormality. Results of the lab studies are pending. Ultrasonogram of the left hip shows small amount of fluid. Which of the following is the next step in the management?
Ready?
Is it transient synovitis?
I think so.
Okay.
So it's ibuprofen therapy. Depression most likely. This most likely, the most likely diagnosis in this otherwise healthy patient is transient synovitis of the hip. Transient synovitis inflammatory condition involving the synovial lining of weight-bearing joints, with the hip being commonly affected, classically present in children recovering from viral infection, with pain on weight-bearing, lethargic gait, refusal to ambulate, tenderness over the joint, and pain elicited with range of motion. Vital signs are normal. Lab studies with the exception of increased marker inflammation such as ESR and CRP. Lab studies, with vital signs are generally normal, as are lab studies, with the exception or of increased inflammatory markers. Antecedent viral infection has been reported in up to 30% of cases. Diagnosis involves exclusion of emergent or urgent conditions such as cellulitis, septic arthritis, osteomyelitis, and fracture. Okay. Treatment is supported in involve rest plus NSAID. If there is diagnostic uncertainty, arthrocentesis to exclude septic arthritis, along with imaging to assess osteomyelitis or fracture should be performed. In this case, the patient likely has transient synovitis as ultrasound shows a small amount of fluid in the patient, has no history of trauma. In the setting of, yeah, yeah, got it. Next.
So transient synovitis is age 3 to 8, preceded by viral infection, well appearing afebrile child, low grade fever. There is limb and hip pain. And on diagnosis, ESR, CRP, WBC, everything normal, but small effusion on ultrasonography. Management conservative, NSAID, full recovery within 1 to 2. weeks, and recurrence is uncommon. Okay. A 16-year-old boy comes for an examination prior to the participation in school sports. A painless mass is palpated. A painless mass is palpated in the scrotum. The mass decreases while supine, and a bag of warm sensation. Okay. The boy states he did not notice it previously. Which of the following is the most likely diagnosis? Okay.
It's varicocele caused by incompetence of the spermatic vein. They are more common in the left scrotum and may be asymptomatic or present with a dull, achy scrotal pain and heaviness. Physical exam will show palpable bag of worm-like mass that increases in size when standing and improves with lying down. Diagnosis is often clinical but can be aided by ultrasound. Varicocele are associated with infertility, testicular atrophy, and they may be managed symptomatically or treated with surgical correction. Next.
A 57-year-old woman comes to the office because she is concerned about her risk of osteoporosis. Her 65-year-old her 65-year-old recently sustained a hip fracture. Her 65-year-old sister recently sustained a hip fracture. 1 year ago, the patient sustained a fracture of the right wrist in a fall. He has no other history of serious illness. Menopause occurs 10 years ago. Her only medication is daily vitamin. She has smoked one pack of cigarettes daily for 30 years. She has a sedentary lifestyle. She is 5 feet tall. Weight is 50 kg. BMI is 22 kg per meter square. Our pulse is 64 per minute. Blood pressure 120 by 60. Examination shows no abnormality. The patient advised her to stop smoking and begin calcium supplementation and begin weight bearing exercise program. Which of the following is the most appropriate next step in the management? DEXA scan is not done. Oh, after oh,
Ready?
1 second. Oh,
Okay.
patient sustain list. 1 year ago, the patient was sustained a fracture. Okay.
So it is DEXA scan now. Osteoporosis and osteopenia are metabolic bone disorders characterized by diffuse low bone density. The most common risk factors are age, smoking, chronic inflammatory disease, steroid use, estrogen depleting conditions. Such demineralization and low bone density is often asymptomatic but increases the risk of fractures, most commonly involving the hip, vertebra, distal radius. Diffuse osteopenia can limit the appearance and detection of fractures on X-ray. Screening for osteoporosis utilizing DEXA scan is recommended for all patients either at age 65 or earlier in those who have at least one risk factor. Common risk factors include family history of hip fracture, prior fragilities, fracture, smoking history, low BMI, use of steroid. Calcium and vitamin B supplementation are the first line of treatment or prevention of osteoporosis. Reduction of active osteoporosis risk factors should also be pursued, such as stop smoking. Weight-bearing exercise are recommended to slow deterioration of bone mineral density. Biphosphonate inhibit osteoclast activity. They are used once an individual is diagnosed with osteoporosis to reduce the loss of bone mineral density, not A or B. Biphosphonate therapy is indicated for patients with osteoporosis or osteopenia with a high fracture risk assessment tool. Biphosphonates inhibit osteoclast by decreasing bone resorption and increasing bone mineral density, which decreases the risk of fracture. Given this patient does not currently have diagnosis of osteoporosis, and she has not received a DEXA scan to determine this, bifosfonate will not be appropriate at this time. DEXA scan at 65 is the appropriate time of screening for osteoporosis in female patients at average risk. However, in patients with a family history, prior fragility fractures, smoking, low BMI, long-term use of steroid, early screening is appropriate. Okay, next.
So we are doing DEXA scan now for patient has a history of like fracture.
Yes, and the sister also has
Is
osteoporosis.
osteoporosis is family to family run?
Don't think so. Maybe let me see. Fragility, family history of hip fracture. Yeah, the sister has hip fracture. So family history of hip fracture specifically.
Okay, and another osteoporosis, another screening is chronic glucocorticoid use, isn't it? Or
Risk
a,
factor. Uh-huh.
yes. Okay. A 15-year-old girl is brought to the physician because of left ear pain for 2 days. Because of left ear pain for 2 days, she completes long distance open water swimming events and trains in the ocean several hours daily. Vital signs are within normal limit. Examination of the left ear shows erythema and edema of the auditory canal and a small amount of white discharge. Manipulation of the left pinna produces pain. The left tympanic membrane appears normal. After treating this patient for acute condition, recommendation of which of the following is the most appropriate next step to prevent recurrence of this patient?
Hmm. Ready?
Okay.
Ready?
Yes.
So it's daily use of alcoholic acetic acid ear drops. Otitis externa, also known as swimmer's ears, is related to inflammation of the external auditory canal. Otitis externa is associated with moisture that causes breakdown um, of cerumen and skin maceration. Disruption of the serum and skin barrier causes an imbalance of pH and promotes overgrowth of microflora that triggers an inflammatory response. Additional risk factors for the development of otitis externa include aggressive ear cleaning, implanting devices like hearing aids and headphones, allergic contact dermatitis, seborrheic dermatitis, psoriasis. The most common pathogen associated with is otitis externa is Pseudomonas. Clinically, otitis externa patient may experience tenderness upon tragal pressure or pain with manipulation of the auricle. Immunosuppressed patients and diabetes may develop severe complications, including malignant otitis externa. Application of alcohol acetic acid ear drop may gently remove cerumen, desquamated skin, and purulent material, which prevents inflammation and therefore limits the likelihood of bacterial superinfection. For moderate to severe cases of otitis externa, topical antibiotics or topical steroids are recommended. In cases of malignant otitis externa, intravenous antibiotics are generally given. It is not that training in chlorine treated pools only will not prevent recurrence of otitis externa. Otitis externa is associated with the disruption of serum skin barrier commonly associated with moisture. Swimmers may prevent recurrence of this condition um, by using alcohol acetic acid drops to gently remove the residual serum and desquamated skin after swimming. Let me
Okay.
see. No, I have
Next.
this one. Sorry,
So sorry.
one more.
Yes.
Daily use of hydrocortisone ear drops, topical steroids are used for the treatment of acute otitis externa. Hydrocortisone help reduce inflammation associated with the condition. When used for long duration, hydrocortisone and other topical steroids induce cutaneous atrophy, while hydrocortisone drugs may be used to decrease acute inflammation associated with otitis externa. They do not prevent recurrence of the condition. Okay, next.
What it is external. Also swimmers here. Alcohol acidic I haven't seen like okay. A 31-year-old woman comes to the office because of 2 month history of progressive fatigue and lack of energy. During this time she also had 2.3 kg weight loss, and despite no changes in appetite or exercise, she has 2 year history of frequent diarrhea. She has 2 year history of frequent diarrhea. Uh, she has not had any abdominal pain, but does have flatulence, which is worse when she runs. She is an avid runner and is presenting for her sixth marathon. Her medications are oral contraceptives, over-the-counter loperamide as needed. She traveled to Peru 8 months ago. She is at 168 centimeter, 5 feet 6 inch tall, weight 66 kg, temperature 99, pulse 60, respiration 12, blood pressure 110 by 60. Examination shows no abnormality. Lab studies are shown. Hemoglobin 11, hematocrit 33, MCV 72, leukocyte count 6,700, serum ferritin. Isn't it low?
What?
Ferritin.
No, okay. No, it's normal.
Okay. Results of the metabolic profile are within reference range. Refers Results of the metabolic profile are within normal range. Which of the following is the most likely cause of this patient's diarrhea? Most one should runs. Peru.
Hmm. Oh, when she runs.
Oh, no, man.
Hmm. Ready?
Okay.
Hmm. It is villus atrophy. Villus atrophy in the small bowel is characteristic finding of celiac. Is a gluten-free sensitive enteropathy that's mediated through immune intolerance of the protein gliadin, commonly found in wet products. This results in inflammatory infiltration of the proximal small bowel, which leads to characteristic intraepithelial lymphocytosis, villus atrophy, and cleft hyperplasia. Malabsorption of substances in the proximal small bowel ensures weak present with symptomatic chronic diarrhea and weight loss. Steatorrhea and nutritional deficiencies. Iron deficiency is a common cause of anemia in patients with celiac disease. It commonly presents with microcytosis with a MCV less than 80 and an increased red blood cell distribution, with indicating the release of premature erythrocytes, which are larger from the bone marrow. The measurement of serum iron and ferritin is likely to show decreased concentrations, such as in this patient, which can confirm that I thought ferritin was normal. It says normal on the thing. Abnormal small bowel absorption in celiac disease results in abnormal serum dysallose and fecal fat testing.
The
Dysallose,
reason, yes,
dysallose is absorbed passively in the proximal small bowel. Reduced serum dysallose indicates reduced small bowel mucosal surface area for absorption. The increased concentration of fecal fat indicates intestinal and absorption of lipids, also seen in the presence of abnormal small bowel mucosa. It is not, where would I CND? It's not the enzyme deficiency such as exocrine pancreatic insufficiency. Rises for insufficient pancreatic enzyme production and secretion, often in the setting of chronic pancreatitis. It leads to inadequate digestion of macromolecules and resulting malnutrition, presenting with diarrhea and steatorrhea. This patient does not have a history of pancreatitis, which usually presents with nausea, vomiting, and severe epigastric abdominal pain. Blah, blah, blah. Enzyme deficiency may also describe lactase deficiency, which results in flatulence, bloating, and diarrhea following consumption of foods containing lactose. Intestinal hypermotility can present in patients with irritable bowel syndrome. Irritable bowel syndrome is characterized by intermittent abdominal pain that is relieved by bowel movement and associated alteration in bowel habits with intermittent episodes of diarrhea and or constipation. Patients with irritable bowel syndrome do not have malabsorption or iron vitamin deficiencies. Okay, next.
next. An 86-year-old man is brought to the hospital because of 4-day history of cough diagnosed in the emergency department as pneumonia. The patient's medical records include signed and notarized living will dated 2 years ago and indicates his desire for no cardiopulmonary resuscitation or ventilation in the event of the incapacitation, administration, and comfort measures only. Upon admission, the patient requests full resuscitation. The patient requests full resuscitation if his status should decline. The patient is oriented to person, place, and time. Initially, only oxygen via nasal cannula and antibiotics are administered, but overnight the patient's status worsens. In the morning, the pulse oximetry uh, on 40% oxygen administered via face mask shows an oxygen saturation is 85%. Which of the following is the most appropriate next step in the management?
Ready?
Wait 1 second. Okay.
So it's provide ventilator support. Regardless of advanced directive or prior court status documentation, physicians need to assess all patient court status at each hospitalization as the context of each hospitalization differs. The patient or the patient decision maker, legal guardian, or durable power attorney should be given the opportunity to update the patient court status. The patient expresses a preference to be full code, which signifies that life prolonging care can be administered while the patient is alive. Respiratory support, intubation, if lung function declines. And after the patient's heart has stopped cardiopulmonary resuscitation, this preference supersedes his previous expressed preference for comfort care only, in which only medications that promote comfort and are continued, while medications that solely prolong life are typically discontinued. Advanced directives are legal documents that enable patients to dictate their preference for end of life care ahead of time. Advanced directives are especially important when patients become incapacitated and are no longer able to verbalize their wishes or care. However, capacitated patients can express wishes that supersede the preference outlined in the advance directive. Include, yeah, since this patient is oriented and able to express a clear preference, the medical team should ventilate him. Yeah, next.
Okay. A 24-year-old man comes to the office because of 1 week history of fever, sore throat, and diarrhea. The patient says that he was evaluated in the urgent care clinic 3 days ago, and results are rapid streptococcal test, heterophil antibody test for infectious mononucleosis obtained at that time were negative. Symptomatic treatment for viral respiratory infection was recommended, but the obtain any form patient did not obtain any from his pharmacy. He has no history of serious illness, takes no medication. The patient reports that he has no oral receptive or anal receptive sex with men, and that his most recent sexual encounter was 2 weeks ago. The patient, he does not use condoms. Today temperature is 101, pulse 96, respiration 16, blood pressure 124 by 17. Physical examination shows there are three oral ulceration and anterior cervical lymph nodes that are slightly tender to palpation. The remainder of the physical examination show no abnormality. Which of the following studies is most likely to establish the diagnosis?
Mm, fever, sore throat, and diarrhea. Ready?
Okay.
Mm, so it's HIV viral load. This patient with lymphadenopathy, fever, weight loss, diarrhea most likely has acute HIV infection, known as acute retroviral syndrome. The presentation of primary HIV infection can vary significantly between patients, with some experiencing mild fever while others experience severe mononucleosis-like syndrome. The time between infection and onset of symptoms is variable, with incubation time lasting several weeks to months. During acute infection, there is a high degree of viral replication followed by widespread infection of CD4 T cells. The T lymphocyte count may drop transiently, which is often normal in early HIV infections unless patients present with signs of opportunistic infection. Initial lab evaluation includes the use of fourth-generation HIV tests, which states for HIV P24 antigen and antibodies combined with direct measurement of HIV viral load using reverse transcription PCR. It is common in early HIV infection for patients to have a negative fourth-generation test, but high viral load, this is known as the window period. The window period varies depending on the kind of test used, including viral testing, though viral testing generally has the shortest window period and is therefore the most reliable test to detect infection. Once the diagnosis is made, lab studies should be sent for mutational analysis and genotyping, but this should not delay the immediate institution of treatment with antiretroviral therapy. Typically include combination of at least three different drugs from at least two different antiretroviral classes. It's not E. Oh, what is E? Throat culture for Neisseria is not the most appropriate next step. Patients with gonococcal pharyngitis can also present with fever and sore throat. However, it's not common for them to present with diarrhea and oral ulcerations. Okay, making it unlikely diagnosis in this patient. Okay.
Okay, next. During a routine health maintenance examination, a 15-year-old girl says that she was used marijuana with friends on her with friends on 4 occasions. Occasions. She is healthy and doing well in the school. She requests that her parents not to be told about marijuana use. In addition to counseling her about adverse effect of marijuana, which of the following is the most appropriate intervention at that time?
Hmm.
Ready?
Second, between C and A, follow up exam with the patient. Yeah, I guess ready. We'll see. Parental consent is required for most medical care of minor patients younger than 18. Exceptions include medical care related to sexual activities like STI or pregnancy or contraception, substance use, and life-threatening medical or psych conditions. Okay. Emancipated minors may take their own medical decision. For these sensitive or time-sensitive issues, patient confidentiality and autonomy is favored over ethical principles. Respecting a patient's wishes about disclosure of medical info can build therapeutic alliance and increase the chance that patients will continue to share sensitive information in the future. As such, the physician should respect the patient wishes to keep marijuana use confidential. The physician should establish regular follow-up to monitor for adverse consequences of marijuana use and the development of use disorder. It's not e. Urine toxicologists may provide useful info about the full scope of the patient's substance use in the future. However, this patient appears to be sharing honesty about her current substance use. Performing urine toxicology as a first step is likely to rupture the therapeutic relationship and decrease the chance this patient shares sensitive information and collaborates in treatment in the future. Okay, next.
Next. A 47-year-old a 47-year-old woman comes to the physician because of 1 week history of progressive pain and swelling of the left knee. She has pain with walking at the rest. She has pain with walking at the rest. There is no history of trauma. She has hypertension, type 2 diabetes, mellitus, asthma. Her medications are insulin, beta adrenergic blocking agent, and a daily inhaled corticosteroid. She is 158 centimeter tall, weight 136 kg, BMI 55 kg per meter square. Her temperature is 37, vital signs are within normal limit. The knee is tender, swollen, warm, and erythematous. There is severe pain with passive and active range of movement. The plain extreme of the knee show periarticular osteopenia. The joints is narrowed medially. Which of the following is the most appropriate next step in management?
Ready?
Yes.
It's aspiration of the knee joint. Septic arthritis classically present with painful red swollen joint along with systemic signs of fever, chills, myalgia, arthralgia, nausea. Septic arthritis results from a bacterial infection of the synovial joint space, most commonly by Staph aureus. The affected joint discloses pain upon passive range of showed swelling and erythema on physical exam. Tocentesis is indicated for evaluation of monoarticular erythema and swelling to evaluate for septic arthritis, which characteristically reveals purulent synovial fluid with greater than 50,000 leukocytes. Serum tests may also show leukocytosis and increased inflammatory markers. Treatment involves urgent IV antibiotic with patient often requires surgical irrigation of the joint. In this case, the most likely diagnosis is septic arthritis because of the patient presentation of increased temperature and red joint with yeah. The most appropriate next step is aspiration of the knee to perform joint free analysis. It is not the MRI of the knee can be useful in cases of traumatic injuries affecting ligament tendons and meniscus of the knee. In this case, the patient did not sustain any trauma. Septic arthritis is the most likely diagnosis because of patient presentation. Aspiration of the knee is next step. It is not E. Not E, naproxen therapy may be reasonable treatment option in acute or gout or osteoarthritis. In this case, there is concern for septic arthritis, so joint aspiration with subsequent analysis of joint fluid is the most appropriate next step. Next.
Okay. Mm, a 55-year-old a 55-year-old man comes to the physician with his wife because of 6 month history of daytime drowsiness. His wife his wife reports that he has had increased snoring, which he has had increased snoring, which is especially loud when he sleeps on his back, but he does not stop breathing for prolonged period. The patient has 15-year history of hypertension treated with hydrochlorothiazide. He is 175 centimeter tall and weight 82 kg, BMI 27 kg per meter square. Vital signs within normal limit examination show increased intensity of the pulmonary component of the ST. Which of the following is the most appropriate next step in the match? Is it sleep apnea?
Think so. Ready?
Yes.
There's polysomnography. Headaches that occur in the morning. Oh, it's even really bad. That occur in the morning. Daytime sleepiness and loud snoring are frequently reported by patients with untreated OSA. This patient is likely experiencing sleep-related hypoventilation as a result of OSA. Clinical features of untreated OSA include excessive daytime fatigue, falling asleep at inappropriate times, loud snoring, and disrupt sleep-wake cycle. Risk factors include male sex, obesity, congenital or traumatic anatomic abnormalities of the oropharynx and upper airway, neuromuscular disorder, sedating medication. Untreated OSA is associated with hypertension. Diagnosis is made via polysomnography. Testing management consists of lifestyle changes like weight loss, dietary modification, increased activity, changing sleep position. Avoiding sedating medications and substance continuous CPAP while sleeping. Second line therapy includes oral appliance such as mandibular advancement devices for symptoms refractory to CPAP use and surgery for cases of obstructive lesions of the airway. Chronic untreated OSA can result in pulmonary hypertension, which may manifest with heart murmurs or loud pulmonary heart sounds. And an eventual right side heart failure. It is not ECG. No, it's echo is not the most appropriate next step in management, though it may be indicated following polysomnography. This patient Presentation raises suspicion of increased right-sided cardiac pressure, which will be diagnosed definitely with echo, though he shows no other signs or symptoms at present. Patients with congestive heart failure have shortness of breath, edema, and potentially JVD. This patient does not display other signs of. Yeah, next.
Okay. A 65-year-old girl, 65-year-old woman comes to the office as a new patient to refill her prescription after relocating to the area. She reports feeling well. She has history of hypothyroidism, bipolar disorder, schizophrenia, which are well controlled with lithium carbonate, non-triptyline, olanzapine, levothyroxine vital signs are within normal limit. Physical examination show discloses a flat effect. No additional abnormality are noted. Results: hemoglobin A1C 5%, sodium 139, potassium 5, BUN, calcium is high 11.9, blood urea nitrogen normal, creatinine is higher 1.6, albumin normal, LDL 100, TSH normal, AST still normal, and 25 hydroxy vitamin D is high. Results of the HIV and hepatitis C are negative. After reviewing the patient's result, a follow-up examination is scheduled 3 days from today. In addition to measuring serum lithium concentration, which of the following is the most appropriate to perform at this time? Is it MM?
What?
Sorry, multiple myeloma.
Oh, um, hmm, 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 hmm.
Hypercalcemia, creatinine is slightly high.
Creatinine, urea, PTH is high, bone density. I mean, she's 65, so we should definitely do a bone density beat. Should be urinary calcium, PTH. What is PTH? Very
Okay.
probably bone density. Nice PTH. Good. Primary. I'll read this one. Primary hyperparathyroidism presents with hypercalcemia, which in turn presents with nephrolithiasis, chronic bone pain, abdominal discomfort, and psychiatric disturbances. Hypophosphatemia, so periosteal bone resorption and end-stage kidney disease. Excessive production of PTH results in increased serum calcium concentration due to osteoclast activity, intestinal absorption, and renal tubular absorption. Serum phosphorus concentration is decreased secondary to increased excretion of renal tubules. Patients without findings consistent with hyperparathyroidism, such as this patient with hypercalcemia, should undergo further evaluation with measurement of PTH. Once confirmed, imaging study may localize the parathyroid adenoma hyperplasia of carcinoma. It is not bone density test, is not the most appropriate next step for this patient. But this patient does meet the criteria for osteoporosis given her age and sex. DEXA scan, a DEXA scan to evaluate her bone health will not lend information to why she has an increased calcium concentration. Because of this, PTH will be assessed for her. And it's not urinary calcium concentration, it's not necessary current is not necessary currently. Patients with CKD commonly have increased excretion of calcium in the urine as they are unable to reabsorb and maintain serum concentrations over time. However, this will not provide further diagnostic information about the underlying cause of her condition. Okay,
Okay,
next.
next. Okay. An asymptomatic 42-year-old man, 1 month history of essential hypertension, comes for a follow-up examination. He has been moderately obese 20 years and follow-up of high calorie, high fat diet. He drinks 4 to 5 cups of coffee daily. He has smoked 1 pack of cigarette daily for 20 years. He drinks one beer at night. He drinks one beer at night almost daily. He has a sedentary lifestyle. He is 5 feet 9 inch tall. Weight is 100 kg. BMI is 33 kg per meter square. Pulse is 78 per minute. Blood pressure 148 by 94. Examination shows no other abnormal. Which of the following is the most effective method to decrease the blood pressure?
Hmm. Ready?
Yes.
So it's weight loss of 20 pounds. Weight loss of 20 pounds is the most effective intervention to decrease this patient BP. On average, the patients who are overweight or diagnosed with obesity, the loss of like 1 pound of body weight correlates with a drop in mean blood pressure by 1 mmHg. Continue aerobic exercise at least several times per week will also help reduce this patient BP. Other interventions that are frequently helpful include dietary salt restriction. Although many patients with essential hypertension will eventually require pharmacologic therapy to reduce the BP below the current goal, which is 130 over 80. Particularly in young patients or those with ongoing hypertension, despite the use of three medications, including diuretic, screening for causes of secondary hypertension should be considered. Abstinence from alcohol is unlikely to have a meaningful effect on blood pressure in this patient who only drinks, and he doesn't drink a lot. Male patients with hypertension who drink three or more drinks per day should be advised to reduce their alcohol intake. Smoking cessation is unlikely to affect this patient BP. In the long term, smoking has been shown to raise BP transiently while smoking the cigarette and in whatever because of increased activation of sympathetic nervous system. The effect of on the BP is transient with pressure returning to baseline in 15 minutes finishing the cigarette. There have been no clear association between smoking and hypertension. Okay, next.
An 88-year-old woman comes to the office for a routine health maintenance examination. She has osteoporosis treated with alendronate. She takes a vitamin D supplementation. The patient underwent a DEXA scan. The patient underwent a DEXA scan within the past year. She has demonstrated a stable bone density. She has demonstrated a stable bone density with a T-score minus 2.3. She is still active in her country, but she lives alone. BMI 21. She has never smoked cigarette, does not drink alcoholic beverage. Vital signs are within normal limit. Physical examination discloses no abnormality. In addition to refilling the prescription of the alendronate, which of the following is the most appropriate next step in the management?
Ready?
Wait 1 second. Okay, yes.
So is obtain depression screening. Depression screening is a routine preventive health measure recommended for all adults. However, elderly adults are under screen for depression. As depression is relatively prevalent in older adults and easily treatable, routine depression screening should occur. Other screening in elderly patients include screening for abdominal triple A, in men aged 65 to 75, breast cancer for women older than 40 with life expectancy more than 5 years, and colorectal cancer for adults older than 45 with life expectancy greater than 5 years. This patient is advanced in age, so cancer screening are unlikely to be beneficial. Patients older than 65 should also be concerned about healthy lifestyle, including whatever all these things. And it's not D&E. Schedule other mental status exam is incorrect. Any physician can perform mental status exam. Physician should regularly monitor the patient's mental status for behavior, affect, mood, and cognitive. No order is needed for this patient. A schedule of follow-up DEXA scan now is not necessary. DEXA scan should be repeated every 2 years for patients with osteopenia osteoporosis. Okay, next.
Okay. A 77-year-old woman comes to the office because of 1 week history of a decreased appetite, nausea, and occasional vomiting. She also reports fullness and discomfort in her abdomen and abdominal cramps that have awakened her on several occasions. Her last bowel movements was 5 days ago and was characterized by loose stool 30 years ago. She underwent hysterectomy for leiomyoma uteri. She has 10-year history of intermittent urinary incontinence. Her only medication is oxybutynin. Colonoscopy 3 years ago showing no abnormality. He appears frail. She is 157 centimeter tall. Weight is 57 kg. BMI 23. Temperature is 37. Pulse 80. Regular. Respiration 14 per minute. Blood pressure 130 by 85. Examination show warm, dry skin. The lungs are clear to auscultation and percussion. Cardiac examination show no murmur. The abdomen is soft and diffusely tender, and there is no rebound and organomegaly. Rectal examination shows firm stool in the rectal vault. Which of the following is the most likely cause of this patient's current symptoms? Soft motor, no farm stool. Farm stool in the rectal.
Ready?
Yes.
That's my thing not working. Okay. Fecal impaction, loose stool in the setting of hard stool in the rectal valve. Increased stool burden suggests overflow diarrhea in the setting of severe constipation. Chronic severe constipation with fecal infection in the rectum can occur in the setting of decreased mobility, opiate use. Anticholinergic use like oxybutynin, which suppresses bowel peristalsis and increases the rate of constipation. This patient episode of loose stool occur because only liquid can pass adjacent to the impacted stool. The first line treatment for severe constipation with fecal infection is administered of enema. This works by introducing fluid into the large bowel, which serves to expand the intestinal tract lumen, soften the impacted stool, and stimulate peristalsis. Modification of this action should also occur as increase in fiber in the diameter of opioids and introducing soft stool softener or osmotic agents in the medical regimen. It's not adhesion, most common cause of bowel obstruction in a patient with a history of prior abdominal surgery. Obstruction of the small bowel
Your
occurs from
sound is floating. Like
oh,
I can hear the half and the rest of the half is in the air.
what should I
Yes.
call back?
Sorry.
Should I hang up and call back?
Now it's clear. Can you tell me again anything?
Okay. I was saying, should I hang up and call back?
No, no, now it's okay.
Okay. Obstruction of the small bowel occurs from partial or complete blockage of the small bowel lumen and typically presents with nausea, vomiting, and constipation, obstipation, abdominal pain, and abdominal distension. This patient has a soft abdomen without distension, making small bowel obstruction less likely. Firm stool in the rectal wall is more suggestive of fecal infection. Okay.
Next. A 22-year-old man comes to the office for a follow comes to the office for a follow-up visit. She received a diagnosis of chlamydia trachomatis 3 months ago. He was tested after his partner was found to be infected. The patient has mm, mm, the patient has never been symptomatic. He and his partner were treated with azithromycin. He has 5 lifetime female sexual partners. He has used condoms inconsistently. He does not elicit drug. Examination shows no genital lesion. In addition to Neisseria, gonorrhea, and HIV testing, the patient should receive testing which of the following: STD. The patient is tested after no.
Ready?
Wait one sec.
Hmm.
Okay,
Where is the? I changed my mind.
ready?
Yes. Oh, wait. Wait. Did I? Is this the answer or is this one? Yeah. So it's chlamydia. This patient should receive testing for chlamydia given his history of previous infection and unprotected sexual intercourse with multiple partners. Chlamydia is a wait. I thought he just got tested for chlamydia. I mean, chlamydia is a STI that classically presents in men with urethritis, dysuria, urethral discharge. However, it can also be asymptomatic. For
Where
this
is the
reason,
problem? You
hmm?
look at the screen.
Oh,
Your screen is stuck.
oh, so you don't see me reading. Okay, let me
No,
hang up and
that's why. That's why. Okay, I said okay. Hello, can you hear me now?
yes, I can hear you. Can you see my screen?
Okay, now I don't know
Okay.
what happened.
Yeah, it always does that around the end. I don't know why. Chlamydia is a STI that classically presents in, yeah, I already read that. However, it can be asymptomatic. For this reason, chlamydia as well as Neisseria is recommended by USPSTF for all sexually active patients under 25. Complications of undiagnosed infection in men include epididymitis and reactive arthritis, as well as possibility of further transmission to additional patients. Diagnosis is made with NAT, and treatment consists of either doxycycline or azithromycin in combination with ceftriaxone, with latter for Neisseria. The risk for reinfection in patients previously treated with chlamydia is high. As such, patients should be retested approximately 3 months after treatment to ensure that infection has resolved and they have not been reinfected. Got it. It's not HPV. It's sexually transmitted viral infection that can cause cervical, vulvar, and penile carcinoma and condyloma acuminata. Testing for HPV can be done in conjunction with pap smear cytology in women, but it's not part of routine diagnosis for active STI infection, as many patients will have transient infection that clear on their own. No further testing is indicated is incorrect. The patient was previously infected with STI and continues to have unprotected sex. He is at risk for infection with chlamydia or new infection with Neisseria or HIV. He should therefore undergo testing for STI infection in order to prevent sequelae or disease or further transmission. And it's not type 2 HSV, more frequently characterized by similar lesion on the genitalia. Wait, it's not type 1. Vesicles followed by ulceration and crusting, more frequently on the areas of the mouth. Other symptoms of genital herpes include dysuria. Diagnosis of herpes can be clinically given the classic appearance of infection or viral culture of any vesicles. Routine testing is less meaningful and not performed, as many patients have positive serologic studies for herpes, but no evidence of active or treatable infection.
Okay, next.
Next.
A 70-year-old man, 70-year-old man with type 2 diabetes mellitus and hypertension comes to the physician for a routine examination 6 months ago. Following a 6 months ago,
Hello?
yes,
Oh, okay.
6 months ago, uh, following myocardial infarction, he underwent coronary artery bypass graft that involved harvesting the saphenous vein. She, he says he feels well. His medication are metformin, metoprolol, lisinopril. Before his operation, he walked 3 miles ago. He walked 3 miles ago. 3 miles ago, he has not resumed walking because he says he lacks the desire. On further questioning, he says he has not resumed any sexual activities. He feels tired on. He feels tired. What am I reading? Because he feels tired on most days, and he does not want to leave his. My adrenaline fall down. Okay, he does not want to leave his house. His blood pressure is 140 by 80. Vital signs are examination. There is no lower extremity edema bilaterally. Which is worse on the left? Which of the following is the most appropriate next step in the management? Is it DVT or is it anything else? Is it depression?
I feel like it's more depression, but it can be DVD. We could say. No. mm,
Three, not questioning. Okay, genetic. Okay, let's see.
okay. So is administration of geriatric depression scale. This patient is likely to meet criteria for MDD. Symptoms of MDD include 2 or more weeks of at least 5 of the following: depressed mood, decreased interest in exercising or socializing, guilt or worthlessness, decreased concentration, psychomotor slowing, agitation, suicidal ideation, decreased energy, sleep disturbance, appetite disturbance. These symptoms disrupt everyday functioning. This patient demonstrates anhedonia, anhedonia and decreased energy despite his recovery from surgery several months ago. Though some patients are able to express a depressed mood, other, particularly men, patients over 65 and African American, may not initially report depressed mood and or may present with primary somatic symptoms. Treatment of NDD should include psychotherapy and antidepressant. It is not D&E. Doppler ultrasound of the lower extremity assists in diagnosis of DVT. Symptoms and signs include unilateral lower extremity edema, skin pigmentation changes, vein dilation, venous ulcer formation. This patient shows bilateral pedal edema and lacks all the signs of DVT. Fatigue and anhedonia are not common on DVT. Echo can be used to evaluate for systolic or diastolic dysfunction, intravascular volume status, and pericardial effusion. It is commonly used to determine the severity of patients with heart failure. Though bilateral pedal edema is a sign of heart failure exacerbation, this patient feels physically well and does not report symptoms of heart failure, such as dyspnea and nocturnia. His bilateral pedal edema is secondary to the coronary artery bypass grafting. Saphenous vein harvesting can lead to pedal edema, as he reports anhedonia, which is more consistent with MDD than congestive heart failure.
Okay.
You want to
No,
continue? You want to do
okay.
biostat?
Let's stop here.
Okay. You want to stop or you want to do biostats? Or to stop?
How many biased question we left? Okay, let's do some biased. Okay, I forgot.
I think we are in 60. We are in this one. I think we did.
A I study. Oh, sorry. A study of 400 patient. A study of 400 patient hospitalized with diabetes mellitus. Relate. A study of 400 patient hospitalized with diabetes mellitus. Complications show the serum cholesterol level is normally distributed variable with mean is 230 and standard deviation is 10 milligram per deciliter. Based on the study, how many patients would you expect to have serum cholesterol more than 250?
Oh my
1
God,
to
it's tough
20.
question. My brain is not working enough to these questions today.
Then we can stop here.
Yeah, that's why.
Oh,
No, I
okay.
mean
No,
we can do it, but I'm probably gonna get them all wrong. My brain is
no.
not working.
Okay. I think that standard deviation is 10, isn't it? Like if we think that 68, 95, 99 rule, isn't it? One
Okay.
standard deviation. So two standard is like 20. 230 plus 20 equal to 250. They are talking about 250 or more than 250, isn't it? So
Mm-hmm.
95, like the 5%, 5%, like the 10 patient, like 10.
I'm just gonna go with what you're saying, as I cannot, my brain cannot think right now.
Okay, no problem. This is biased. Welcome to the biased. It will happen in the exam, no doubt. What, what, like before the exam, my brain starts stopping working.
Yeah, cannot do it right now.
Okay,
Okay, next.
next. 5, 5, okay, 10, I think that. Okay, a large study of the serum cholesterol uh, level in patients with diabetes mellitus reveals the parameter is normally distributed with the mean is 230 and standard deviation is 10. According to the result, 95% serum cholesterol observation in this patient lie in between which of the following limit? Okay, it is easy, maybe. 95
Mm,
is 2 standard deviation, then I think that 210 to 250, isn't it?
makes sense.
Yes. The sense is all the thing remains. A patient a patient has his blood pressure. A patient has his blood glucose level measured The population mean blood glucose level is then subtracted from the patient's blood glucose level. The result is then divided by the standard deviation. If we assume that the blood glucose level in the population follow a normal distribution curve, the value obtained the best referred as.
Okay, tell me.
I think that not F value. Chi is categorical excluded, not correlation coefficient. Either T or Z score, isn't it?
Okay, probably. I told you my brain is not working for biostats today. So I'll
Okay,
go with whatever you say.
okay, I think that
Yes,
it is Z score.
this score. Okay.
T score is for like, what can I say? For the osteoporosis. So I am not thinking about it. Okay, next.
What? What? The, oh, well,
I
for
am, I am,
osteoporosis in
uh,
biostats.
exclude whatever you think. Okay, next. Don't waste our time. Just go to the next question. These questions are not that tough, but we are in
They are
the ocean,
not. I think, yeah, I
isn't it?
think it's just that yeah, we've done a lot of questions today. I think it's just that they are not tough. It's just that we started with something else because family medicine has a lot of topics.
N-
It's not like when we were doing
If it
OBGYN.
happens, what we will do in the exam? You got my point.
Yeah.
That is the most. That's why I feel sad when I read the biostat. That that's why when I start feeling sad. Okay, stop it. Next, HbA1c level is measured in diabetic patient placed on intensive insulin therapy. The distribution curve, the distribution of the value is shown on the slide. Which of the value is indicated? The mean, median, and mode. Positive. Mean is this one is easy, but I am.
Wait, what is it?
That
Median.
is the basic concept. And positive, if it is positive, like you told me one of the mnemonic that positive
I did.
deflection,
I did. I did. I know.
but
I know. I,
I remember that you said, but I forgot what you have said.
okay.
If
Okay.
it is positive deflection, like mean is the least,
Mm, 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 mm,
like
mm.
3.3 is the mean, median is the middle number, and the mode is the a 3 to 1. What do you say? You have said something like in case of
Forgot. Forgot. I mean, median, middle. Okay, fine, makes sense.
and mean is the like uh, the sloping
Forgot.
part, the
Uh huh.
positive, the sloping one is the mean, the 3. I
What
think
is
that
the sloping part? Sloping. Oh, the one that goes down. That's what
yes,
you mean. No, that's not it. No, that's not right.
I think that 3 to 1 is the right.
So B, B
A.
as in boy. A. Okay. Okay. Let's check answers.
The easiest question came, but this 4 is very easiest question, isn't it?
Mm-hmm.
So what happens? That's why I am very scared. So your duty is to make me study biostat every day. Okay, let's see the answer. Okay, yeah.
Okay.
Hello?
Yeah, I can hear you.
Yes, okay. Okay, normal distribution curve. Normal distribution is the most. common statistical distribution tested on usable exam. Most common statistical distribution tested on usable exam. We should read plenty of time. Okay. Many
Exactly.
real life continuous parameter follow normal distribution, systolic blood pressure, serum potassium level, blood glucose level. There are several properties that help to define normal distribution graphically. A normal distribution forms a symmetrical bell shape. The mean, median, mode, a variable that follows a normal distribution, are equal or very close to each other. The 68, 95, and 99 rule holds for the normal distribution. It states that the 68 percent of all observations lie within a standard deviation of the mean. 61 standard deviation, 95 2 standard deviation, 97 3 standard deviation. Uh, in question 1, the cutoff of 250 2 standard deviation above the mean and leaving the tail 2.5% of the right, 2.5% on the right, and 2.5% of 400 is 10 patient. Okay, I don't. So you got the idea.
Mm-hmm.
Okay, a normal distribution with the mean 0 and variance is what called standard normal distribution. Any variable that follows a normal distribution can be transformed to a standard normal distribution by using the approach described question 3, subtracting the mean from all values and then dividing the standard deviation. When this process is applied to any given value in the data set, the value of z-score is obtained. The z-score indicates how many standard deviation at a given value is from the mean. Skewed distribution are asymmetric, having a tail to the right, positive skewed, or left, negative skewed. A positively skewed is shown on question 4. Mood is positive skewed, correspond to the peak of the mood is the peak of the curve. Median is either to the right because it bisects the number of the observation, where the mean is even further to the right because it is affected by high values of the at the right tail. Okay.
So the mean is median is the middle, mean is huh? Three. Oh, mean is the tail. Okay, you're right. Mean is the
Mean is
tail.
the tail, a median
Mode
is
is
the middleman, and mood is the peak, correspond to the peak of the curve. Mood peak, mood peak. You have said something uh, regarding this. Can you uh, tomorrow you start with this, like this concept? You got my point.
oh my god. Where am I gonna find? I don't know where I
Y-
found the because I haven't started studying biostat, so I don't know where my mnemonics I don't know.
But you haven't like created any note or something for
The
this.
biostat, no, I just have his the things I showed you last time.
Okay.
That, that's it. So
Then
I don't know.
start with 1 to 2 topic, like 1 to 2 question of the bias. Then we can start with the questions. You got my point, because this this is creating problem. When we are dealing with the bias at the new question, everything becomes new. I think that if we start the previous question, what we have solved, we may got wrong on that too.